Multiple myeloma is actually a very challenging diagnosis to arrive at because patients don't come in with one classic hallmark sign or symptom. In fact, patients typically come in with a relatively vague sign or symptom, of which the top three are fatigue, anemia, or back or bone pain. And of course, those are so common in the primary care world. A primary care provider sees that almost on a daily basis, but doesn't see multiple myeloma on a daily basis. In fact, we know from a recent study and multiple studies before it that the average patient who's ultimately diagnosed with multiple myeloma visits their primary care provider 3 times with signs and symptoms consistent with myeloma before the diagnosis is suspected and ultimately confirmed. So it really becomes important for us to recognize that as primary care providers, we are the gatekeepers, as it were, of multiple myeloma. Although approximately 2/3 of patients are diagnosed with myeloma through the primary care portal, as it were, there are other ways in which patients are diagnosed with myeloma, which includes nephrology, neurology, cardiology, the emergency department, and even hematology oncology. And so when those signs and symptoms initially present, that fatigue, that anemia, that bone pain, or any of the features of the CRAB criteria with elevated calcium, renal insufficiency, anemia, and bone disease, it is really important for us to pursue the right testing for multiple myeloma. Before I discuss testing, let me also comment that one of the confounding reasons why it is difficult to arrive at the diagnosis of multiple myeloma, especially in higher risk populations for myeloma, like patients of African American descent, like Hispanic patients, is the presence of diabetes. There is a tremendous overlap between the signs and symptoms of diabetes and those of multiple myeloma, such as anemia, such as renal insufficiency, such as proteinuria, or even neuropathy. And so it becomes very important to also suspect myeloma in that patient who we may be attributing these things simply to diabetes. So how do we arrive at the diagnosis of multiple myeloma? Well, we begin with the basics. And so we begin with the CBC. That CBC will provide us not only the hemoglobin level, but of course it will give us the white count and the platelet count to direct us towards marrow function. Secondly, basic biochemistry, which would include the calcium level, the creatinine level to assess renal function, and a patient's total protein to see if there is potentially an abnormality within the protein levels. This then leads us to the myeloma-specific testing. And historically, we've encouraged the use of the serum protein electrophoresis. And it is still a fundamental test and very important to obtain. But without 2 other tests along with it, it is clearly incomplete, as up to 20% of myeloma patients will not have an abnormality on the serum protein electrophoresis. So along with the serum protein electrophoresis, it's critical to order the immunofixation so we can identify the type and size of that monoclonal protein, but also the serum-free light chain assay. That serum-free light chain assay measures both kappa and lambda levels and arrives at a ratio. And when that assay is abnormal, that may well be indicative of a monoclonal gammopathy and indeed multiple myeloma. So when the serum protein electrophoresis, immunofixation, and serum-free light chain assay are ordered, we know that our sensitivity to detect multiple myeloma is nearly 100%. This is also consistent with the key guidelines that we follow from the International Myeloma Working Group, or the IMWG, as well as the College of American Pathologists, or the CAP guidelines. Both of these guidelines note the importance of adding the serum-free light chain assay to the traditional serum protein electrophoresis and immunofixation.